Thank you so much for inviting me to talk about this important topic, very dear to my heart. He had asked me about the current treatment for advanced breast cancer. And I sent him a title saying, "Is there a cure?" Dean sent back, "Well, we know we are really looking for talk about the treatment of cancer." I said, this would be a most intriguing topic. And knowing that this was going to be the last talk after lunch, I thought, let's keep everybody's attention totally focused. What could be better than just your possibility? And in case we are still not focused, here is, I'm an astronomy buff, and this is the James Webb Telescope. So going from the world is flat to looking into the heavens, thanks to research, technology, use of science, they fit in a 21-foot gold-plated mirror telescope into the nose of a rocket, blasted it off into space, lodged it 1 million miles from Earth, and scanning the skies for, scanning the heavens, I should say, for exoplanets or the other inhabitable planets. Is life out there? So amazing pictures, what technology can do. Hubble, the telescope that was most advanced till December 2021, and these are the images from the James Webb Space Telescope. So just absolutely amazing stuff. So we have come down to Earth to look at what we can do for our breast cancer patients. So I'll tell you, when I decided to go into the field of oncology, that was back in 1997, I wrote out my personal statement saying that the top part was cancer is death. So advanced breast cancer, generally people would think, well, the cancer has already spread to different areas, it's a death sentence. Not so. So I knew about the federal government, and Bill Clinton was pretty instrumental in cancer research, funding cancer research, and I decided to go into this field, and I have never regretted it for one moment. And that is all because of how exciting the field of oncology is, all thanks to research. So we've heard the other presenters. Dr. Schmidt was very good with her presentation about cancer. We heard Sumedha. Generally speaking, again, this is going towards the basics. And quick overview, normal cells have all these genes that are preventing the normal cells from taking off and dividing uncontrollably. So there are the tumor suppressor genes, there are the proto-oncogenes. They are all keeping things nice and quiet. Protein translation is limited. Anytime there is a mutation, and we heard about the environmental factors, the genetic factors, anytime there's a mutation, this is what happens. This is how cancer takes off. So the mutation results in production of proteins, which you can think of as receptors that go to the surface of the cell. And these cancers, they can lead to uncontrolled proliferation of the cell. So uncontrolled cell division, and Dr. Schmidt mentioned apoptosis. That is normal cell death. Our cells undergo death. These cells, these cancer cells, these mutated cells are basically immortal. They will keep dividing. They are not going to die. So before you know it, you have one cell that had the mutation, and they divide and make a huge mass. As these tumor cells grow, they eat into blood vessels and lymph channels, and then they travel throughout the body, they lodge into different organs, and that's where they start creating trouble. When they grow enough, they can even secrete factors inside their microenvironment that will make blood vessels go towards them and makes those tumor cells grow. It is an absolutely unbelievable mechanics of what goes on with the cancer cells. So again, this is a magnified image of a cancer cell. On the surface, you see those receptors. And then you see all these other dots, which are the autocrine factors that are going to stimulate the cancer cell growth. One of the receptors on breast cancer cells is the estrogen receptor, right? So breast cancer is generally thought to be hormone-driven. Majority of the cases will be hormone-driven. So here's the receptor. The blue dots are the estrogen receptor. The red stuff is the estrogen in a premenopausal woman. The ovary is the main source of estrogens. Also, fat cells. So people who are obese, they're going to make a lot of estrogens. And another gland that sits on top of the kidney, called the adrenal gland, is another one that makes the female hormones. So once there is interaction of estrogen with the estrogen receptor, it leads to a number of chemical reactions inside the cell, and that can lead to uncontrolled DNA duplication, and that can lead to tumor cell creation and growth. So this cartoon again represents the postmenopausal physiology, how there is the in the fat cells and adrenal glands, there is the androstenedione that floats around, and using the aromatase enzyme is converted into female hormone, and so forth. So scientists have been able to develop drugs. You've heard about tamoxifen. Tamoxifen binds to the estrogen receptor, prevents the female hormone from attaching to the receptor, and that keeps the cell from dividing. In a postmenopausal women, we have the aromatase inhibitors, the aromatics that you have probably heard about, Femara, Aromacin, and those medicines work on that top part. That aromatase enzyme is inhibited by those drugs, preventing the production of female hormone and stopping that cascade. Then there are other drugs that we use to manipulate this estrogen receptor. Estrogen receptor downregulators are there. You've heard about the injections Faslodex and so forth. So that is the estrogen receptor pathway. So when patients come in to us in our clinic, as an oncologist, we first say, well, it is advanced breast cancer, but what part of the body is affected by this cancer? So we immediately think of them as in two different sets. One is the women in whom the cancer is limited to the bones and soft tissue. So skin, muscle, bones, versus ones in whom the organs are involved, the liver, lungs, brain, that sort of thing. Totally different pathways for the two of them. The bone-only disease and the soft tissue-only disease generally tends to be hormone receptor driven. And these patients can do very well for years just by hormone manipulation with the drugs that we just talked about. On the other hand, if it's organ involvement, it's a different animal, very aggressive, and even if it's estrogen receptor, progesterone receptor positive, we tend to use chemotherapy drugs and try and get the cancer under control. And once it is under control, if they are female hormone positive, then we try and use the anti-estrogens and so forth. So chemotherapy, I think of chemotherapy really as a very, very stone age way of treating cancer, because you really are literally taking poisons and you are injecting them into your patient, and those drugs are designed to kill anything that is growing fast. So fastest growing cells will be the cancer cells. They will die. The drug gets inside, generally disrupts the DNA duplication, but then there are the other cells in the body that are trying to provide you with the patient with normal function, and that's where all the side effects come in. So you have your hair follicles. The hair follicles are making hair. You lose your hair. Not too much about that. What about the bone marrow cells? Bone marrow makes blood. Blood is life-giving. It fights off infection. Your white blood cells go down. You're at risk for infection. People actually get bad infections. They can die from having a bad infection while on chemotherapy. Red blood cells get affected. The patients are generally tired and and so forth. There can be toxic effects on the heart can weaken, there can be neuropathy that patients can develop. So those images that come to mind of a cancer patient really looking sick, having nausea, vomiting, all of that is because of chemo. We have to get beyond that. So we have to look deep into the cancer cell, figure out where can we attack the cancer and get away from chemotherapy. So these are the generally used drugs for patients who have bone-only disease, soft tissue-only disease, generally hormone receptor positive. So we use the Arimidex and there are some CDK4/6 inhibitors that make them work even better. They can be a combination of Faslodex and Arimidex. One of my patients is going 4 or 5 years now just by getting that shot and taking that pill, and no sign of any cancer. So pretty impressive stuff. Then with the chemotherapy we talked about, these are the common chemotherapy drugs that we use and different class of agents. We start with the most active ones, and then we go down the list once the patient's tumors stop responding. They are very smart. They figure out ways to bypass the chemo. They even develop pumps on their cell membrane that can pump out the chemotherapy drugs. So it is absolutely unbelievable what these cancer cells are capable of doing.
Actually, it's too bad they weren't good because they'd be very beneficial. They're kind of smart little critters, aren't they?
They are, yes. So these would be the chemo. We want to go away from the chemotherapy stuff, though. So that's when, yeah, go ahead.
Yeah, I mean, getting away from chemotherapy drugs. Okay, so since we want to go that direction, and then there are the other drugs like the aromatase inhibitors that are, looking at, being so effective. It just puzzles me why we aren't doing more education on aromatase inhibitors that are naturally available in certain foods. Since we want to go that direction anyway. Do you have a feel for why? Just because it's taken us so long to recognize the role of nutrition in health?
You're absolutely right. And so again, as we heard the other speakers today, I think lifestyle change, what we put inside our body. There are 50 to 60 billion cells inside us every day that have to be replaced. They die and they have to be replaced. And if you don't have good food inside, good water inside, it is going to create a problem. So I tell my children every day, don't eat. So you're right about those things. But so if we want to go beyond chemotherapy, then we have to put on our thinking hat. We have to be like those NASA scientists, right? So the scientists looked inside the cancer cells and they found out that these receptors that are present on the cancer cells. One of them is the HER2 family or the HER family of receptors. The HER2 is overexpressed in about 25 to 30% of the breast cancer patients. So the top cartoon, if I could have a laser, that would be awesome. The top, this one doesn't. The top cartoon, those red, violet, green, and like a green, that shows the HER2 family. The violet one is the HER2, which is the one that is thought to be really active in the growth of breast cancer cells. So these are receptors, and in this particular cartoon, in the lower part, you see that when there is overexpression of HER2, these receptors can get auto-cleaved. They can be cut off, and that can lead to automatic triggering of phosphorylation or chemical reactions that can make the cell grow really fast. Also, with these little hands that they have, they can attach to other HER2 receptors, what is called the auto-dimerization, or with the other HER2 or the other HER family of proteins, what is called the heterodimerization. Once that happens, it leads to those multiple chemical reactions that will eventually lead to the tumor cell division and exponential growth. So keep those receptors in mind, and the cascade of chemical reactions that lead to the tumor cell division. So this particular HER2 receptor, when it is overexpressed, it leads to excessive tumor cell growth. And patients used to do very poorly when they used to have breast cancer that expressed the HER2. So this is the pre-Herceptin era. And women who had the HER2 positive, and when they were followed over time, early breast cancer followed over time, they did a lot worse than the ones who had HER2 negative tumors. That all changed. How did it change? The scientists came about with a drug called Herceptin. It's a monoclonal antibody that is developed in the lab against the HER2 molecule. So this lower cartoon shows the trastuzumab, or the Herceptin molecule, the antibody, and it attaches to the HER2 receptor, and it inhibits that autocleavage, it inhibits the dimerization. It also, being an antibody, it triggers other immune cells in our body to get to that site where the interaction between the antibody and the HER2 molecule has happened, and makes the other cells chew up the cancer cell. The Herceptin and the HER2 complex is internalized into the tumor cell, and where it is degraded, and that particular HER2 receptor that was present on the surface of the cancer cell is no longer there. So different ways that this little antibody can work. This is what it showed in the clinic. So this was reported in 2001, really groundbreaking stuff. So patients who had the HER2 positive breast cancers, and they were given chemotherapy with Herceptin, versus the lower graph in every single one of them are the women who had only chemotherapy, no Herceptin. The survival, the progression-free survival improved significantly with the use of Herceptin. And it held true with different chemotherapy drugs. So adriamycin cytoxin, very active drug, you use with Herceptin, the graph looks better. The progression-free survival is better. Taxol, again the same thing. Why stop there? Let's take a look deeper into the HER family of receptors. So the scientists then figured out that there are different extracellular domains. So the Herceptin, or trastuzumab, attaches to domain 4. But there is a domain 2, which plays a very important part in that interaction between HER2 and other HER family of receptors. So they developed a drug, pertuzumab, or Perjeta, which binds to the extracellular domain 2, preventing that dimerization. And guess what happened? When the combination was given, the patients who received the combination of Herceptin, Perjeta, and the chemotherapy, they did a lot better than the women who only got the Herceptin and the chemo. So we are seeing incremental improvement in our progression-free survival and how our patients respond. But again, why stop there? Let's do a little bit more science, a little bit more research. So then came in the concept of antibody drug conjugate therapy, or ADC. This is, again, just is so exciting in the field of oncology to be having these drugs. So this is Herceptin, or trastuzumab, backbone, which works great, right? It stops the internal cascade, it stops the internal cleavage, it downregulates the HER2 receptors, but once it goes inside the cancer cell, it's taken inside, and when the complex is being degraded, that's when the payload is released. So not chemotherapy that will kill every fast-growing cell in the body. This is targeted therapy that is going and attaching to the HER2 overexpressing tumor cells, getting inside, releasing the bomb, and inhibiting the DNA duplication. This particular one is Kadcyla, and it works on the microtubule complex and causes the mitotic catastrophe, essentially meaning that the DNA duplication just doesn't happen. So TDM1 or Kadcyla was one of the first antibody drug conjugates that came about. And what did it do? Well, when the patients were given TDM1 or Kadcyla, this trastuzumab loaded with the payload, and compared it to just the trastuzumab, our patients' progression-free survival significantly got better. Why stop there, right? So this is the latest kid on the block. And again, it is absolutely unbelievable what kind of stuff is going on in oncology. So this is the Enhertu. And this one uses an even more powerful payload attached to the trastuzumab molecule. So same thing, goes inside and releases the payload, and it kills this tumor cells unbelievably well. So this is a study that showed the top one is the new kid on the block, trastuzumab deruxtecan, or the Enhertu, and the lower one is the trastuzumab emtansine, or TDM1 or Kadcyla that we talked about in the previous slide. So this one, again, it's not a little bit of diversion in the graphs, it's a huge difference in progression-free survival. It's actually a 72% improvement in progression-free survival. So you see how with research, we are able to achieve these amazing results in clinic. So here is what we do for our HER2-positive advanced breast cancer patients. They come and we give them the Herceptin, Perjeta, and the chemotherapy. And once they go to, they progress in that, then they go on with the Kadcyla or the Enhertu and so forth. Enhertu is going to go to the front line. So you're just going to see more and more of it.
Just, I guess, in recognizing the advancement of how we do things, we didn't used to even test for the HER2 status of it, right? When did we start doing that?
So around that time, I remember being in the oncology fair with one of the attendings who was doing research in this back in around the year 2000. And she was telling how in her lab, she was finding that whenever patients are being given this trastuzumab, unbelievable cell kill. So that right around that time.
Yeah, but it wasn't probably a regular part of a biopsy even in like 2005.
No, by then it was actually being used. 2005 was when it was reported that in patients in whom cancer has not advanced to metastatic phase.
Oh, okay.
So in early breast cancer, if you are given the Herceptin, then it shows a significant improvement in their time for overall survival and progression-free survival. So by 2005, it was pretty much mainstream.
Oh, it was?
Yeah.
Okay.
Okay, so we're making some progress, but then comes in even more exciting stuff. So who created this machine? This is the most unbelievable piece of machinery ever conceptualized, right? And you and I are alive because of our immune system, our immune defenses. Ever since we were born, we were exposed to viruses and bacteria that would have finished us off had it not been this immune system, right? So the immune system consists of B cells, which will make antibodies, and T cells, which go and attach to the foreign cell and release toxins inside. So this is what B cell is doing. A foreign cell, it recognizes it doesn't belong to the body, it's not a citizen. It attaches to the foreign cell, releases toxins. The B cell makes the antibodies that go and attach to the foreign cell, kill it off. Now, why does the immune system not kill the normal cells? That happens because the citizen cells of the body, they express a protein called the MSC class of proteins. And they tell the immune cells, these immune cells are floating around in our body, through our tissues, they're looking around for any problems, they're like police, looking around. And anytime that they come across and they sense what's going on, oh, the protein looks fine, it's a citizen, I'm not going to bother it, floats on to different things. So that's why it doesn't kill the normal cell. But anytime it detects a foreign cell, that protein is different on a foreign cell. It is going to immediately trigger an alarm. It is going to attach to that cell and it's going to release chemicals, toxins inside that's going to destroy that foreign cell. Generally, T cell will kill one-to-one kind of a fight is what happens. Now we talked about a lot about the environment and how the importance of exercise with the good food that you eat. You remember the times of 80s and 90s when people with HIV/AIDS, they were developing cancers. Remember Philadelphia movie, the Kaposi sarcoma is showing up on Tom Hanks' face, and he's trying to hide it. Anal cancer, things like that were coming on. That's because the immune system is severely disrupted in AIDS, and that allows tumor cells that are forming in all of us all the time. They gain a foothold, and they would wreak havoc in those patients. Aging is another thing, like we heard today. As we grow older, things just start breaking down, and cancer cells have a chance to survive any attack from the weakened immune system. The cancer cells are very smart. They can even look very similar to the normal citizen cells. They may not have as many mutations that the immune system may say, hey, it's still my, it looks a little different, still a citizen, I'm going to move on. Also, these cells have some proteins on their surface which are called the checkpoint molecules. Think of them as little breaks on the immune cell, on the tumor cell that stops the immune cells from attacking the tumor cell. So PD-L1, PD-1, CTLA-4 are the important checkpoint molecules that we have tested so far. Keep those in mind. So when the tumor cell expresses these checkpoint molecules, the immune cell has a break, gets against a break. It's not going to be able to kill that cell. These tumor cells can also release chemicals in the microenvironment, like interleukin-10, TGF-beta, which will again deactivate the immune cell. So lots of ways that these cells kind of survive in our body and thrive. So with that knowledge, we said, well, what can we do with that knowledge? So put on the thinker hat, and cancer vaccines have been developed. So this is just a very slow process. The cancer vaccines, the promise is there, but just a very slow process. So identifying the abnormal proteins on the surface of the cancer cells, making a vaccine, injecting it into the patients, and then hoping that the immune system is going to make antibodies and the T cells will recognize it and kill the tumor cell. So that's one. The super exciting one is the CAR-T approach. Okay, so this one involves modifying the patient's T cell. So we'll talk a little bit about it, but CAR-T therapy, remember that, it is absolutely amazing stuff. This is what they do in the CAR-T approach. CAR-T means chimeric antigen receptor therapy. The patient's T cells are removed from the blood. So they are taken out by a machine called an apheresis machine. The T cells are removed. They are taken to the lab, and in the lab, the genome of the T cells is modified using either a viral vector, or there are newer techniques, CRISPR and Cas9. Using that, they modify the T cell so that the T cell starts expressing on its surface the chimeric antigen receptor. The chimeric antigen receptor, it's showing that cartoon is showing that, the T cell with the chimeric antigen receptor. The outside part, the extracellular domain, is going to recognize the cancer cell, the proteins that are being expressed on the cancer cell, and as soon as it recognizes it, it's going to bind to it, and the chimeric part, the internal part of this receptor, is going to activate the T cell and is going to attack the cancer cell and finish it off. And remember the one-to-one fight that the T cells used to do? Here, one cell is going to be able to kill multiple tumor cells. Auto-recruit, auto-divide, and soon you have an army of cells finishing off the tumor. So this is,
Do you assume that the T cells that you're collecting initially are good, healthy T cells
Yes.
to begin with?
yes.
And does it go from the same patient?
Yes,
In the
so it
back.
can be both, two types. It can be auto or allo. So that gets a little bit more complicated, but it could be from the patient itself, or it could be from a donor.
Okay.
Yeah. So the promise is amazing, and the CAR-T therapy came about just around 2017. The first one was approved around that time, and it's been approved mainly for the hematologic malignancies. So patients with diffuse large B-cell lymphoma, with multiple myeloma, they are the ones in whom we used to see in the clinic ALL, pediatric ALL, or young adult ALL, acute lymphoblastic leukemia. These patients, when standard treatments, they had failed them, they had failed transplant. And you give them the CAR-T cells, and they achieve a cure. It's unbelievable stuff. So really, really promising. Now the use of CAR-T cells in solid tumors is going at a slower pace. However, breast cells express a lot of proteins that can be utilized in this approach. And there are, in fact, multiple trials going on nationally and internationally looking at the CAR-T approach in advanced breast cancer. Then I will talk to you about what we are actually doing in the clinic and what we actually have it. So CAR-T cells, CAR-T therapy is really available in specialized centers. It requires a lot of preparation, $1 million treatment, that sort of stuff. But again, the technology behind it is amazing. The results are amazing. This is checkpoint inhibitors. Remember that break on the tumor cell that will prevent the immune cell from attacking the cancer cell? The scientists have been able to develop monoclonal antibodies, just like that Herceptin that we talked about, but this time directed against these checkpoint receptors. And the ones that you probably have heard about, they are showing up all over the airport, in the magazine and everything, Keytruda, or pertuzumab, or nivolumab, right? Opdivo, and they keep coming. So they are amazing in that they remove the brakes from the immune system, and the immune system becomes supercharged to the point that it will kill any cell which looks even a little bit different from the normal body cell, normal citizen cells. And the results are amazing. So 2014 was around the time that this therapy was approved for melanoma, and National Cancer Institute doing a lot of research. Our cancer center at our Brigham Medical Center participates in the NCOR program, the NCI Community Oncology Research Program, and we recruit heavily for our 26 hospital system and multiple BLCCs. We were the number 2 recruiters for research studies through the NCOR program for last year. So we do a lot of research and great stuff coming up. So when in breast cancer patients we use this immune checkpoint inhibitor, Keytruda, along with chemotherapy, you see the results again, the overall survival improved significantly compared to the ones that were given chemotherapy alone. So again, incremental improvement. I'll also tell you, I personally have, so we have in our practice, lung cancer. So what started off as an approval for melanoma has panned out, because it's the same process in pretty much other cancers too. So anytime there is overexpression of the PD-L1 or these PD-1, we are able to use these drugs, and we are these drugs have been approved for melanoma, lung cancer, kidney cancer, head and neck cancer, colon cancer. I have in my own practice patients who have been treated with the immunotherapy, and their cancer is nowhere to be found. Metastatic cancer, nowhere to be found. Breast cancer, I have had the opportunity to treat one lady that was about 3-4 years ago, and she came in with metastatic cancer, triple negative breast cancer, and we gave her immunotherapy. And she had received a lot of radiation, and there were some complications from the radiation, inflammation around the heart. There's a lining around the heart called the pericardium, so that was inflamed and became very hard. We weren't very sure whether it is coming from the radiation or whether it is coming from the immunotherapy, because immunotherapy, once you remove those breaks from the immune system can become supercharged, and it can attack normal cells too. So we weren't very sure, so she had no sign of cancer. We took her off the immunotherapy, and a year and a half later, she had no sign of any cancer, but she was having a lot of shortness of breath. And she went to Mayo Clinic, and I said it's because of the radiation-induced pericarditis. We'll strip that pericardium off, and unfortunately, she succumbed to complications during the operation. But for all we knew, there was no cancer. Metastatic breast cancer, no sign of cancer after immunotherapy. So I think we are making great progress. Now the NASA scientists have their James Webb, and we have the next generation sequencing. So this is what Sumedha talked about a little bit about the somatic mutation testing. So what we are trying to do is, we are trying to see what mutations are present in our patient's cancer. What is driving these cancer cells to grow like this? And there are tests that are available. Dr. Schmidt was talking about how when she was in her high school, there was a guy who was working on the Human Genome Project. It took 18 years and billions of dollars. Collaboration from scientists around the globe, 18 years to figure out the human genome, 3 million base pairs, right? Now you know how fast it takes to decode a human genome? 1 day, $100. So it is absolutely amazing the pace at which this stuff is happening, and that's all happening with next generation sequencing. We are able to feed the patient's tumor DNA and figure out which mutations are driving the cancer. And then with those mutations, there are certain enzymes that have been affected, and the scientists have been able to figure out which chemical reactions are being affected. They have been able to make targeted molecules that work against that chemical reaction being triggered, and that can lead to killing of the cell and preventing their uncontrolled division. So this is just a little bit of a detail of that next generation sequencing. So now, these days, we have, when our patients come in, from the time with the estrogen receptor, the HER2 receptor, the immunotherapy, we are looking at their genome, seeing what mutations are driving their cancer, and so for an example, the NTRK mutation, if that's picked up, the PIK3CA mutation that is picked up, we have targeted molecules, pills that patients can take, and their cancer can get controlled. So I think we are making great progress, and super exciting time to be an oncologist. I do not regret one day that I decided to be an oncologist. It's the most amazing field. The standard of care changes every month. It is like that. So this is our cancer center, and really nice group of people with the COVID and all that. We haven't had a picture, but I grabbed a few of them and got a picture for the talk. So that's basically my talk, I hope. And I see everybody's alert. Nobody's sleeping. Mission accomplished.
Are there any final questions?
I mean, since it's changing so fast, how long before you think that immunotherapy might be standard of care for like breast and prostate cancer?
So those things are standard of care. For triple negative breast cancer, metastatic cancer, and overexpression of PD-L1, we give immunotherapy already.
For advanced.
Correct. So what happens is that when any new way of treating, let's say, cancer comes about, we first start it off with the patients who really have no other choices left, right? So we start with them. And we see, well, there's activity, it's safe, and it can be utilized, then it comes on to from second line or third line metastatic stage 4 cancer patients to maybe first line metastatic cancer, right? First thing is do no harm, right? So once we determine that it's effective, that it's safe, it moves forward, and immunotherapy is, for lung cancer and things, is actually being used in not just in metastatic phases, but in earlier phases. So this is the same thing is going to happen with breast cancer also. We're just not there yet. Research is ongoing, but it is in that process. Now another interesting thing that you will see soon, this Enhertu, the last kit on the block that I talked about, was better than the targeted payload. 3+ is what we use to overexpression of the HER2 molecule. That's when we used to give our patients Herceptin. This particular drug will work even with lesser expression. So all of a sudden, the number of patients who can benefit from these drugs will keep expanding. And this, I'm very sure, is going to be in the adjuvant setting, where the cancer has not spread. You have a tumor that has gone to the lymph node. We're going to give you this drug, and you're going to have a better outcome compared to what you would have had otherwise. So it's all evolving. It all is a big jigsaw puzzle. Every research project that we have, every patient who is brave enough to come in and enroll in these trials is helping us fill up that jigsaw puzzle so that the entire picture is clear. And I'm very sure that my one patient will become hundreds and thousands of women who will be cured of this cancer.
So that's experimental right now, basically.
It's evolving, right? It's an evolving field.
And I
So
wanted to
from
ask
Hubble to James Webb.
As you talked about vaccines, I know that human papillomavirus is one of them. What are some of the other ones that are actually giving vaccines for?
So HPV is the big one. So the young kids, they are being, and my wife was asking me whether our kids, my daughter is just turned 12, whether she should have. Absolutely. That little thing can prevent bad cancers of the head and neck, of the female organs, and absolutely a great idea for vaccination for that. So HPV is the big one. Yeah.
All right, we have one more question.
Just a real quick one. I realize this is about breast cancer, but have there been any advances in esophageal cancer? That's what my husband has.
Esophageal cancer, I'll tell you, immunotherapy is doing amazing stuff there.
Is it?
So, it is. So again, in my practice with metastatic cancer, I have at least 2 patients who were given the immunotherapy, and in esophageal cancer, there is also overexpression of that HER2 molecule, HER2 receptor, and combining Herceptin-like drug and immunotherapy, the checkpoint inhibitor, we were able to achieve no sign of cancer on the PET imaging.
Is that in early stages?
No, advanced cancer, metastatic cancer. So
Oh, man.
now the thing is that it should pan out over time, but it's really remarkable what we are doing. We're not making them sick. It is giving them targeted therapy, understanding how cancer biology is. It really is, I'm telling you that as an oncologist, it is not a sad thing that people say, oh, it must be a really hard treat. No, it's not a hard treat, because we are able to give our patients some amazing treatments that work very well, and in the end, it literally is, there are times we have to say goodbye. But neither I nor the patient has any regrets, because we had a good time, we tried our best, you know. So that's how I feel.